Going into the actual webinar itself, Aaron is one of my good friends and a very talented ophthalmologist. He graduated from Cambridge with a distinction. He ranked third nationally for his ophthalmology applications, and he also ranked within the top 5 for his Duke Elder exam, which is a national ophthalmology exam. So you're in very good hands. If you have any questions, post them in the chat and me and Azim will try and get to them. But without further ado, I will let Aaron crack on. So I hope you all enjoy.
Perfect. Thanks, Shoaib. Can you all hear me, first of all? Is that loud enough? Perfect. Brilliant. First of all, thanks for having me. Thanks for the over-the-top introduction. Shoaib's one of my good friends, and these guys at Biomedicine are doing some really, really cool stuff, giving you these kind of webinars for free, and hopefully it's useful. And yeah, so I've been asked to talk about ophthalmology emergencies. My name's Aaron, as Shoaib said. I'm an ST1 ophthalmology trainee working in London at the Royal Free. And I'm going to be basing this on ophthalmology emergencies. And then there'll be a bit of an exam focus as well, as with some of your other webinars. And then at the end, I'll cover a few quick things on other things that could come up in your finals to hopefully give you like an hour, 10 minutes of everything you need to know in ophthalmology. And after this, hopefully you can tick that off the kind of to-do list of things to cover before your exams. Questions, if you have any questions throughout, then put it in the chat, please. I'll try and address them kind of in little gaps between each kind of case. So that's all I wanted to start with. Let's get started. Okay. So straight into it. First case, we've got here a 4-year-old boy is brought to A&E with redness and swelling of his right eyelid. He says he has been having recent flu-like symptoms for the last 4 days. So just have a think of that. Look at kind of what you think might be a kind of key pointers in that question, the age, things like that, the symptoms, and just have a think. Put in the chat, if you don't mind, what kind of diagnosis are you thinking about already? Okay, got a few people. Brilliant. Okay, perfect. And I'm just going to switch over now to our first question of the day. Brilliant. So most of you have got orbital cellulitis is what you're thinking, which is absolutely correct. So have a look at this question now. Log on to Mentimeter, so it says it at the top there. And which of the following features would be most concerning for something like orbital cellulitis? So this boy does have orbital cellulitis. That's what we're thinking at the moment. Which of the following features would be most concerning for orbital cellulitis? I'll give you guys about 20, 30 seconds. Got visual acuity reduced, full range of eye movements, a right RAPD, conjunctival injection, and normal visual fields. Great. Which one of the following features would be most concerning for orbital cellulitis? And we will stop there. So let's see what you guys have come up with. Okay, so 64% of you gone for reduced vision, 29% for right RAPD, 7% for conjunctival injection, and none of you have gone for full range of eye movements and normal visual fields. So the correct answer is the right RAPD. So ophthalmology is one of those things that once you realize what they're looking for, you'll realize why some answers are definitely more likely than others. So first of all, we'll go through this very quickly. Right RAPD is the correct answer. And RAPD is where you do a swinging light test. So if we just focus on, if you shine a light into one pupil, the pupil should constrict. That's a parasympathetic nervous system. And that's your direct response. And you should see a direct and a consensual response. And the RAPD test is a swinging light test from one pupil to another. So when you have a positive RAPD, rather than the pupil constricting, the pupil actually dilates. And there's two main causes of an RAPD. And that's the easiest way to think about it. As an ST1, this is still what I think when I see an RAPD. There's a retina problem, so we'll come on to things like a retinal detachment, or there's a problem with the nerve, and that's what we're thinking here, the optic nerve. And that's what you're worried about with orbital cellulitis. And we'll talk about this in a few slides. Has your infection, your cellulitis, a cellulitis is usually a skin infection, has it spread all the way back to affect the optic nerve? And that's what you'd be most concerned about. So that's why we've gone for that over here. Reduced vision, I can see why lots of you have gone for that. That's kind of your trap answer there, because reduced vision is also concerning with other things in the eye, such as a preceptal cellulitis. Full range of eye movement is absolutely normal, so it's great that none of you have gone for that. Same with normal visual fields. That's a normal finding, so you wouldn't be concerned about that. Conjunctival injection sounds very fancy. All it means is a red eye. It's where the white part of the eye becomes red. So the sclera is covered by a thin layer of conjunctiva, which is see-through. When that gets injected, you see red because the vessels are dilated, and that's why it's called conjunctival injection. It's a very non-specific sign. There's not even one ophthalmology condition which you can go red eyes worrying. So here we've gone RAPD as a correct answer. So if we go back to the slides, there we go. So let's get on to the first case. The main thing to think about, we've got a child when you're thinking orbital cellulitis or preceptal cellulitis, is names and different names, basically, because there's lots of different names for this. The common name is orbital cellulitis, but it can also be called post-septal cellulitis, and we'll talk about what that means. Post means after, as you know. Septal, just like we've got the septum in the heart, we've got the septum, which is a wall in the eyelids. So this just basically means the infection has spread behind that septum in the eyelid. And this is your emergency, and that's what we're going to be covering today in this case. The other one that you're less concerned about, but was the other differential, is a periorbital cellulitis. Most people call that a preseptal cellulitis. So they use these two names interchangeably. I remember as a med student, I always got confused because I'd read about orbital cellulitis, or I'd read about something specific, and the question might say post-septal, and I'm thinking, wait, is that something different? Is that something completely different that I just haven't covered? So just think about that as other names. And this is only affecting the first layer of the eyelids. So if we move on from this. So orbital cellulitis, what is it? As I briefly explained, it's where the infection has spread past the orbital septum. So you can see from this picture over here, this is a cross section of the eye. You've got the eyelids over here, the eyelashes. You've got your eyeball here, which is the white part, which is the sclera covered by the conjunctiva, your lens, your vitreous, which is your jelly, and then here's the optic nerve. So this blue layer is your orbital septum. So your preseptal cellulitis is when it hasn't breached this kind of layer, and your orbital cellulitis or your post-septal cellulitis is when it spreads behind this. So that's why when we're questioning what would you most concerned with an orbital cellulitis, you'd be most worried if the infection has spread all the way to affect the optic nerve, and that would give you an RAPD. So an orbital cellulitis is anything that's past the septum. What are the causes of this? So first of all, there's usually an infection of some sort. So the most common being a sinusitis. So a sinusitis is, as you know, basically when your sinuses are filled with kind of pus. So you usually get sinusitis when you've got a cough and a cold. So that's why in this particular question, it specifically said this boy has had flu-like symptoms for the past few days. So it's showing you that's a source of the infection. Complication of trauma. So if a foreign body's kind of caused something. Hordeolum, someone's asked what hordeolum is. It's basically a lid bump. All you need to know, it's like a sty. So it's just a bump on the eyelid. And basically, if you can think about it, if there's a pus infection there or a small collection on the eyelid, it can spread further back into a preseptal and then even further into an orbital cellulitis. Dacrocystitis, what's that? That means inflammation of the lacrimal sac. So all it means is another lacrimal sac, so where tear glands are made in the eyelids. When that gets infected, it starts there and it moves further back. Hematogenous is usually in immunocompromised patients, so very, very rare. Risk factors, really important, age. So orbital and preseptal, most commonly, you're thinking kids, especially with orbital cellulitis. And I never really worked out why this was until my consultant really explained it. This septum just isn't completely formed in children. It forms around the age 8 and 9. So that's why in children, especially when you see a red eyelid, you're thinking, wow, this could quite easily spread into the orbit, potentially into the optic nerve. So risk factors, if it's a child with these kind of features, you're really worrying about orbital cellulitis. Organisms, staph and streps. The reason they're the most common is the infections come usually from the skin, and we've got staph and strep kind of sitting on there all the time, especially in the eyelashes. So clinical features of orbital cellulitis. First, I'm going to start with preseptal, because most commonly you start with that first as one of your differentials. Your eyelids are affected, remember, so you're going to get warm eyelids, they're going to be red, they're going to be slightly tender. They might not be able to open the eye as a child because they're so inflamed. That's always going to be there, whether you're preseptal or orbital. What makes you think orbital cellulitis are these kind of features? So fever, so it's a systemic thing. Proptosis, where something's pushing the eye. If you've got an infection that's spread behind the eye, it can push the eye forward. And chemosis. Chemosis is a word that is thrown about in MCQs for ophthalmology. And just to throw it out there now, all it means is where the white part of the eye is edematous, so it's swollen. And it's a very non-specific sign once again, but it shows that the infection has passed the eyelids. If there's one thing that you're going to take from this entire lecture, it's this bit here. Please learn this. The red flag signs of optic nerve compromise. We use this every day as ophthalmologists, and it's most commonly tested. So reduced vision is one of the signs, but it's very non-specific. Reduced color vision, because our optic nerve goes into our cones. So that's affected when the optic nerve is. Mute, I think. I'm hearing lots of sound. Perfect, sorry. We've talked about an RAPD, where you get the pupil dilating when you do the swinging light test. Your reduced visual fields, if the optic nerve is affected, then some of the retinal fibers that go into the optic nerve are sometimes affected. And ophthalmoplegia, so pain on eye movement. So these 5 things are signs that your optic nerve is affected. Okay. The reason why the answer in this question is RAPD is because reduced vision can be from lots of different things, but RAPD specifically says optic nerve compromise. Okay, so you're thinking orbital cellulitis, what do you do for this patient? Someone said, can you please, yeah, so just quickly looking at the chat, would red desaturation be a red flag sign? Absolutely, that's a sign that your color vision is impaired. RAPD is when your pupil dilates rather than constricts when you do a swinging light test, and there's 2 causes of this, which is retinal problems and optic nerve problems. And you do get an RAPD with optic neuritis. Great. So investigations, FBC, CRP, ESR, blood cultures, mainly your inflammatory markers and your infection markers. But the key test here is your CT head. So if it says what is the most definitive investigation, or if you're worried about someone with orbital cellulitis, your investigation is CT head. And you can see here with this arrow, there's a lot of proptosis, a lot of swelling here. And you can see how would you manage this patient? They're usually admitted, especially if they're children who are very unwell, for IV antibiotics first. And then you also need to think about ENT review, because remember, this normally starts from a sinusitis. And just remember, this is an orbital cellulitis is when it's past that septum in the eyelids. So that can cause effect of the optic nerve. It can cause an abscess. It can cause a cavernous sinus thrombosis if it spreads even further. So just think, these are all complications that start from an infection on the outside and spread into the eye. And the reason why it's more common in children is because that orbital septum isn't completely formed. And if they do throw in, very unlikely, how do you manage a preseptal cellulitis? Oral and topical antibiotics and warm compresses should do. Okay. So I was just quickly check the chat. Yeah, the red flag feature is definitely the most important thing. I would do a CT on children because if you're worried about an orbital cellulitis, it could go further back into the cavernous sinus, and that's what you're most worried about. Which antibiotics would you use? Cefuroxime is most commonly used, but for your med school finals, for you guys, I would just learn broad spectrum antibiotics. Okay, guys, great. So that's your orbital cellulitis versus your preseptal. We're going on to the next case now. So have a read of this. A 14-year-old boy is brought into the emergency department after suffering a high impact injury when a football hits his right eye. He has no loss of consciousness, but is complaining of right facial pain. So you've got a ball injury to the right eye. Quite a difficult question. What are you thinking could be the case? What could have happened to this guy's eye? Or perfect, already got it. Yeah, blowout fracture, orbital fracture, brilliant. So if we go to the next question, if I just switch my screen over. Okay, so in an orbital blowout fracture, which I'll explain in a bit, which bone is most likely to be involved? So have a go at that. We've got maxillary bone, zygomatic, frontal, sphenoid, and palatine. If you don't know it, have a look at the answers, try and exclude some of them, thinking about where they are and see what you can go for. It's quite a difficult question, so don't worry if you don't get it. Give you about 15 more seconds. Okay, so let's see what you guys have come up with. Okay, so we've got most of you going for the zygomatic bone, maybe because it sounds cool with the Z, that's what I would have gone for. Maxillary bone and sphenoid about the same, then frontal and palatine bone quite low down. So the correct answer is the maxillary bone. Once again, don't worry if you haven't got this. These are the questions I've picked out are the kind of the really hard ones that could come up in your final. So hopefully, basically after this, you won't have to do much ophthalmology reading because we'll cover most things. So orbital blowout fracture is basically where the fracture is at the bottom of your orbit. So your eyeball sits in your orbit, and the most common site when you get a blunt injury, such as like a ball or a squash ball or a football or a punch. When I say blunt injury, it doesn't actually break the eye, it just kind of hits the eye, is in the floor, and that's where your maxillary bone sits. The maxillary bone covers the floor and the medial wall. Your zygomatic bone's on the other side, so your lateral side, so kind of where your temple is. Frontal bone's at the top. Sphenoid bone, you've got your greater and lesser wing of the sphenoid towards the back of the orbit. And the palatine bone is super, super tiny, so it's very, very unlikely. So orbital blowout fracture, think maxillary bone. Okay, great. So let's go back to the slides to go over orbital blowout fractures. So what is a blowout fracture? Most of you have heard of it. What is it? It's a blowout fracture is when you get a break of one or more of the bones that surrounds the eye. So you can see in this diagram, we've got the eyeball sitting there with all the extraocular muscles, and you can just see the bones there, the bony bit, the bony socket that it sits in, and that's your orbit. And that's what we call an orbital cellulitis, because it's spreading through into the orbital cavity. Why do you get a blowout fracture? Why, when a ball hits the eye, doesn't the eye just break? Why doesn't it just burst open? Well, the eye is actually made as it's a protective mechanism. So when something strikes the eye, the force is actually transmitted into the orbit, and that protects the eye from more serious injury. And it's the thinnest and weakest orbital bones that fracture, which makes sense. And the most common fracture sites are the orbital floor and the medial wall. And you can see here, this is kind of your nose. This is the top of the head. This is kind of your temporal region over here, and this is the bottom. And this purple bone is your maxillary bone, and that is that's the weakest area. So normally, when you get kind of these orbital blowout fractures, the fracture usually happens here in the orbital floor. And just remember, it's the maxillary bone that is most commonly affected. And that's your protective mechanism. On a side, just so thinking anatomy wise, if that's affected, normally the infraorbital nerve leaves through this hole here. So if the infraorbital nerve, which is commonly affected, if you get a break in the bone here, you get reduced sensation in the area kind of just under the eye, infraorbital, so under the eye, so around the cheek area, you get reduced sensation usually with a blowout fracture. So clinical features, eyelid swelling, you can see over here, you've got swollen eyelid. Yep, actually, hypoesthesia, exactly, Jason, from the chat. Pain, someone's punched you in the eye. Reduced vision. Double vision is very common because the muscles can be affected. If you think that you've got a fracture, the inferior muscles, such as the inferior rectus, sometimes get trapped in that break in the bone. So you can get double vision where one eye is moving not with the other. Surgical emphysema, which commonly happens with kind of fractures and things like that. Enophthalmos, so that's when the eye gets sunken in. Or proptosis, which is the opposite, where it comes forward. And that's if you get a big bleed behind the eye. And hypoesthesia, which we talked about. Is it in reduced sensation reversible? Yes, it is. It usually heals over time. So investigation. So blowout fracture, once again, you're thinking CT and facial x-rays. So very basic. CTs is the most common thing, most definitive almost always for ophthalmology. And over here, what you normally see, just to look good if you have ophthalmology placements, you usually get this teardrop sign. So this is your normal orbit. You've got a break in this really thin bone here, and you get kind of herniation, so things dropping through, such as orbital fat, sometimes the muscle, things like that. And that's called a teardrop sign. How do you manage this patient? Most importantly, don't just think ophthalmology, think generally. If someone's been punched in the eye, there's going to have probably other injuries. So ABC, antibiotics, because they've probably got an infection, if they've got kind of an open wound potentially, tetanus vaccine, if there's any open wound. Avoid nose blowing. It's really kind of important tip you have to tell someone, because as soon as they blow their nose, that pressure difference is going to also bring that snot down their nose, but it's also more likely to cause herniation through this hole. So be careful with that, and straight to ophthalmology and oromaxillofacial to see if they need surgery. And surgery is usually based on whether they have double vision. Prescription of antibiotics is almost always. We will talk about optic neuropathy later, if that's okay. And first line, I say, yeah, X-ray first line, but CT is the gold standard, absolutely. Okay, perfect. So that's your blowout fracture. Just want to kind of get a gauge from the chat. Am I going too fast for you guys, too slow, or are you guys happy with the pace? Brilliant. Okay, most of you say it's okay. Tell me if things are going too fast or too slow. Okay, some of the questions we can't answer, me and the bite medicine team will happily stay behind at the end to hopefully answer some questions we don't cover during the presentation. So on to the next case. Have a read of this. A 36-year-old woman presents to a GP with a red right eye for 4 days. She describes pain on bright lights and watering of the eye, and she's a contact lens wearer. So her vision, so 6/6 is basically your equivalent of 20/20 vision. Remember that 6/6 is 20/20 vision. If the number after the kind of slash is higher, that's worse vision. So 6/12 is, you can think of it as one line or two lines worse than 6/6. 6/36 would be even worse. 6/60 would be really bad. So 6/6 is really good. 6/3 would be absolutely excellent. You could be a pilot with 6/3. But 6/6 is your 20/20 vision. So we've got a bit of reduced vision in the right eye. The conj appears injected. Remember that all that means is this area is red. That's all it means. A very non-specific sign. Cornea appears hazy. It's a white collection seen inferiorly. The pupils are equal and reactive to light. So I'm going to switch. Have a look at that again. have a look at the key signs. I'm going to show you the question. What is the most likely diagnosis from a 36-year-old with a contact lens who has reduced vision, a red eye, painful, watering? We've got 5 options: acute angle closure glaucoma, bacterial keratitis, viral keratitis, anterior uveitis, and endophthalmitis. Have a think. 36-year-old, red eye, watery eye, painful, contact lens wearer. It looks quite red. There's that white layer of fluid at the bottom. What are you thinking most likely? Most of you are probably contact lens wearers, think of it. Okay, so let's see what you guys went for. Okay, so we've got 63% going for bacterial keratitis, 24% going for anterior uveitis, and then a few going for acute angle closure glaucoma, a few for viral keratitis, and a few for endophthalmitis. Okay, so I'm going to tell you right now, contact lens wearer with a red eye, that's painful, reduced vision, contact lens wearer almost always is a bacterial keratitis. Almost always you're worried about bacterial keratitis. I had a patient this morning, the eye casualty, referred from A&E, contact lens wearer with a red itchy eye, but the vision was okay. I'm already thinking bacterial keratitis. It was a bacterial keratitis. Almost always bacterial keratitis. We will cover acute angle closure glaucoma today. We will cover endophthalmitis. We'll cover viral keratitis, and I'll talk about uveitis at the end. But we will talk now about bacterial keratitis. So well done if you got that. Viral keratitis, just to quickly cover, is almost always your herpes simplex virus. So think of cold sores in the history, HSV1, HSV2. Acute angle closure glaucoma, you're thinking more really painful eye, watering, nausea and vomiting, and they're usually a hyperopic patient, which means they have a small eye. We'll talk about that later. And endophthalmitis, almost always after surgery or an injection into the eye. So after an intervention that we've done, almost always. So back to the slides. So here in this, when I'm reading this, I'm thinking contact lens wearer straight away, and watering of the eye, red eye. Anyone who did go for anterior uveitis, I'll tell you now, I can see why. Pain on bright lights almost always means anterior uveitis. We'll talk about what that is. That's inflammation of the front part of the eye. But because of the contact lens wear, you're always going to think keratitis. It's a big, big risk factor. Okay. If that wasn't there, if it didn't say contact lens wearer, but you've got pain on bright lights, you're already thinking anterior uveitis. We'll talk about that later. So really important take-home point, contact lens wearers think bacterial uveitis. Sorry, bacterial keratitis, sorry. Okay, so yes, Claire is the same as bacterial keratitis, absolutely. So what is a keratitis? An itis means inflammation. Keratitis is the cornea. So inflammation of the cornea. It's almost always infective, and we can call it by bacteria, viruses, and fungal. As I said before, viruses are normally a herpes simplex virus. If you've got a contact lens wear, most of them are bacterial. They can rarely be fungal, but almost always they're bacterial. That's the most common. Risk factors, the big, big one is a contact lens, contact lens, contact lens. Other risk factors, if you've got any breach in the corneal epithelium, so if you've got trauma, if you've got dry eye, the cornea is less protected by your tear film, which is protective mechanism. And if you're using steroid drops, so just like steroid tablets to make you immunocompromised, if you take steroid drops, your eye is more at risk of an infection. Your cornea is that front surface, which is really important. So you're more likely to get a corneal infection. Quick question in the chat. Amoeba is the fungal version of your contact lens keratitis. So really, that if they're ever going to ask you a question and they say, what is the cause of the kind of, they've done a contact lens scrape and they can see fungi, your answer would be acanthamoeba as the organism. Back to bacterial keratitis, guys. So the most common bacteria is a Pseudomonas in contact lens wearer. That's all you need to remember, Pseudomonas in contact lens wearer. I have put Staph there, but the most common in contact lens wearer is always your Pseudomonas. If they give you findings that suggest it's more fungal, then you're thinking you're acanthamoeba. Features, painful eye, red eye, all very kind of non-specific. Blurred vision, once again, very non-specific. Very specific to your bacterial keratitis is your purulent discharge, so kind of green discharge, but not always. A hypopion, so this is what they described there, where you get usually a clear, straight horizontal line. And what that is basically white blood cells and pus collecting in your anterior chamber. And it's a straight line because it's basically kind of gravity sinking that to the bottom of this chamber. So that's why it's usually a straight line. And your white corneal opacity. So you can see in this diagram here, you've got a really obvious corneal ulcer, and that is kind of the cornea responding to an infection. How would you investigate this? Have a look at the eye with a slit lamp, then put some fluorescein in, and you can see here that there's an epithelial defect. So that's where the front layer of the cornea has actually kind of become eroded by this infection, usually a bacteria, usually Pseudomonas. And how do you investigate further? You take a small scrape from this. This is all ophthalmology doing this, but just so you know, you take a small scrape from this, you send it to the lab, and you grow whatever organisms. Once again, most likely a Pseudomonas. If it's fungal, the most common is acanthamoeba. And how do you manage this patient? If you're thinking bacterial keratitis, almost certainly you start them on topical antibiotic drops, the main ones being the fluoroquinolones, so the ciprofloxacins or the ofloxacins, and you tell them stop wearing contact lenses for usually a month at least. Throw away any contact lens solution that, that you used for that particular contact lens. Okay, so that's bacterial keratitis. Just to cover some of the other answer options, there was a viral keratitis that came up as one of the options. What would make you think more viral keratitis? It's caused by your herpes simplex viruses, so think cold sores. If there's a history of cold sores in your question stem, think viral keratitis. Once again, these are the very similar findings, but this would have a watery discharge. So watery discharge would be viral. A purulent green mucousy discharge, you're thinking bacterial keratitis. History of cold sores we've talked about. If you saw in the previous slide, when I stained with fluorescein, we saw usually a round ulcer. Remember, they're usually linked to contact lenses, which are round. With a viral keratitis, you see something called a dendritic ulcer. It's a very key word that they use. And that's where you see this branching pattern. So it's like these circle bits with like branches in between, kind of like a roots growing out, and that's called a dendritic ulcer. This is pathognomonic for your viral keratitis. So for example, if you've got cold sores or dendritic ulcer, you're already thinking HSV keratitis. How do you treat this? With acyclovir drops. And this, once again, is not usually linked to contact lens. Perfect. Okay. So just going to quickly check the chat, see what kind of questions we've got. So acanthamoeba is a fungal keratitis. Conjunctivitis is just affecting the clear layer in front of the eye, so that's not affecting the cornea. You wouldn't use chloramphenicol drops for the corneal infections. You need antibiotic drops, kind of stronger antibiotic drops, such as your ofloxacins. Perfect. Okay, brilliant. Okay, on to the next case. Halfway through, guys. So we're doing really well. 69-year-old woman presents with severe headaches, blurred vision, and a red, painful left eye. She's vomited twice. So 69, headaches, blurred vision, painful red left eye, and she's vomited twice. And you can see from the picture, the left pupil's dilated. When you have a look, it's bigger than the other side, and it's oval. The cornea is a little bit hazy. So have a think of that, and let's go on to the next question. What is the most likely diagnosis here? The anterior uveitis, optic neuritis, acute angle closure glaucoma, giant cell arteritis, or raised intracranial pressure. Remember the key findings. We've got a 69-year-old lady, suddenly has a red eye, painful, feels nauseous, she's vomited twice, the pupils oval and dilated. What do we think is the most likely diagnosis? Okay, so let's see what you guys have gone for. Brilliant. Okay, so 81% of you have gone for acute angle closure glaucoma, which is the correct answer. Anterior uveitis, remember we're thinking photophobia, so pain with bright lights. Optic neuritis wouldn't give you these kind of symptoms. They'd give you your optic nerve compromise things, which you talked about, which is your reduced color vision, your RAPD, your reduced field, your pain on eye movements. Giant cell arteritis, more kind of scalp tenderness, temporal pain, jaw claudication, shoulder pain, and your raised ICP is your headaches, your tinnitus, things like that. So this is your acute angle closure glaucoma, one of the other ophthalmology emergencies. Oh, sorry. Let's go back to the slides. So just one thing I want to say, we'll come on to actually, why is the cornea hazy? Think about that. Why is the cornea hazy? It's something no one really ever explained to me. We'll come on to it now. So what is glaucoma, first of all? Glaucoma is, most people think it's raised pressure, which it is. That's the most common association, raised intraocular pressure. So the pressure in the eye, not blood pressure, which is the pressure in the vessels, not intracranial pressure, which is in the brain. This is pressure in the eye. And it's when that pressure causes damage to the optic nerve. So you can think, as we saw in previous photos, the eyeball is quite small and it sits in a really small, tight socket called the orbit. So if the pressure in the eye goes up, it doesn't have anywhere to go apart from backwards where the optic nerve is. And that's where you get your optic nerve damage. You've got two main types, open angle glaucoma and closed angle glaucoma. So we're going to cover this one first, your closed angle glaucoma. Before we do that, what actually determines your pressure in the eye? Why, like blood pressure we know is to do with stroke volume and heart rate. What determines your pressure in the eye? It's aqueous. So it's aqueous in and aqueous out. Think of it like taps. So you've got water running in from the tap, you've got water draining from the sink, and then you can block that with your plug, and you got the sink can fill up, and at one point it overflows, and that's when the pressure is kind of in the eye gets really high. So aqueous is made over here by the ciliary body, and it's secreted into what we call the posterior chamber, so kind of behind just behind the anterior chamber. It's secreted into here, it flows out through here and through the pupil. So the pupil is that hole in the middle, which constricts and dilates with light, and then it comes through the pupil, and then this is your anterior chamber. So your posterior chamber, then the pupil hole and the anterior chamber, and then the aqueous leaves the eye through something called the trabecular meshwork. And then it goes into something called Schlem's canal and into the bloodstream. So that's most of it. A very small portion of the aqueous actually comes through into another pathway called the uveoscleral pathway. So rather than going through here, it kind of drains across here, back towards here. Just something to know about with the way drops work. So made here, flows through here, and comes back out into the bloodstream here. Why is the aqueous important? It provides all the glucose, the oxygen to all these parts of the eye. So that's why it's important. So angle closure glaucoma. So what is angle closure glaucoma? The mechanism of pathogenesis is where you get a pupil block mechanism. So it most commonly happens in dark conditions. So in kind of MCQ questions, people say, oh, towards the end of the day, they came in with these symptoms, or while they're in a cinema where it's really dark, they came in with these symptoms to A&E. So what happens when it's dark? The pupil goes into this sympathetic response and the pupil dilates. So if you think about it, this is your pupil size here, this gap between the two iris halves. And when that dilates, the iris moves outwards. So you get bigger pupil, so you can see more light in dark conditions. So what happens is this peripheral iris bunches up and it kind of folds over and you get kind of resistance to the normal flow of aqueous. And so over time, the aqueous can't escape as much, and it starts to build up over here. It bows this iris forward. So this part of the iris kind of starts to bow forward as a mechanism. And that bowing closes the angle here. So rather than being a big, nice, wide angle, it gets really, really narrow. So that's why it's called angle closure. So the aqueous builds up over here, pushes the iris forward and closes that drainage angle. So it just can't escape. And you're probably asking, well, we all sit in the dark, we all go to the cinema. Why does this not happen to all of us? Well, some people are more at risk. So females are more at risk, Asians, especially kind of Chinese Orientals, just the way the eye is formed. You're older, you're more at risk. And small eyes, this is one of the big risk factors, so small eyes. So what we call that is hypermetropic. Most of you are young, probably wear glasses for distance, so you're myopic, you're short-sighted. That means you have a slightly bigger eye. Long-sighted actually is the opposite. So if you've got long-sightedness, you've actually got a small eye. So if you think your eye's already small, the angle's probably already small as well. So you're just more at risk of that closing. So remember that as a big one that comes up in MCQs. If you're long-sighted, and it usually happens when you're in the dark. So angle closure glaucoma, what are your kind of clinical features? This is an investigation technically where we check as ophthalmologists what is the pressure. So the normal pressure is usually anything from 10 to 22. So it gets really, really high with angle closure glaucoma, and it goes high very quickly. And it's that pressure that causes pain. So these are the key features I've put in red. A cloudy cornea. So why is the cornea cloudy? I asked you to think about that. The reason is, if I go back, the aqueous provides all of this part of the eye, the posterior cornea, the iris, all of this with its nutrients, the glucose, the oxygen. And when the aqueous just isn't moving around, the oxygen isn't moving around, so the posterior cornea isn't working as well. And basically the cornea becomes decompensated. And when the cornea isn't working as well, because it's not getting the oxygen and the glucose, it becomes cloudy. That's its mechanism of responding. So you can see the cloudy cornea over here. So you've got cloudy cornea. You've got a fixed oval and irregularly dilated pupil. Why is that? It's due to something called PAS, peripheral anterior synechia. You don't need to learn that word. I'm just trying to explain the mechanism behind it. When you've got your iris bunching up over here, over time, the iris over here sticks to the cornea. So when your iris would normally go back to kind of constricting in a small pupil, it's stuck there. It's stuck. That's what we call peripheral, because it's peripheral, anterior, because it sticks to the anteriorly, synechia. It's kind of like fibrous tissue. So when that sticks there, you've suddenly got this really weird dilated pupil. It's really irregular, and it's not responding when you try and shine a light to make it constrict. And pain, because the pressure is really high and the eye sits in the orbit. And these symptoms are red eye, water eye, reduced vision. They're all present in glaucoma, but they're very non-specific. So these ones in red are really, really important. And how would you treat angle closure glaucoma? The most important thing is to try and bring that pressure down. So if you've got a pressure of more than 40, try and bring it down to below 20 safely. So the way we do this is we use different drops, alpha agonists, beta blockers, steroids. They work in different ways, which we can talk about later. So the agonists, usually they reduce the, agonists increase the drainage of aqueous. Beta blockers normally reduce the production of aqueous. So they work kind of, beta blockers kind of mean that less water is coming from your taps. Alpha agonist makes more holes so it can drain. And you can give systemic kind of tablets. But your definitive treatment, once you've got the pressure to safe levels, is to do something called a laser peripheral iridotomy. So all that means is you're using laser to make a hole. Otomy means hole in the iris. So you can see over here, here's your normal pupil. Here's your cornea. Your iris is your brown. And can you see over here, you've got a really, really small hole. That's not from someone punching the eye. That's deliberately made. And the reason that is you've got another outflow pathway for the aqueous to drain through. So if we go back, rather than it just coming through this big hole here, if you made a hole over here, all the aqueous can come through here. So it's quite clever. It gives you another kind of bypass mechanism. So, and we do that kind of stop further attacks of angle closure glaucoma. We usually do it in both eyes if someone presents, because they're more likely to get angle closure in the other eye as well at a later stage. Okay, so that's angle closure glaucoma. I know that was quite intense. Any questions quickly in the chat, because that's quite a big topic. I want to make sure you guys understand that. Otherwise we can cover them at the end. So the cloudy cornea is because the cloudy eye is because the cornea isn't getting the nutrients from the aqueous, so therefore it isn't working as well, so it becomes cloudy. Age, as you get older, the eye kind of shrivels up a bit. And iridotomy is that small hole which provides another drainage pathway. Alpha 2, well, there's a lot of questions. Okay, I'm going to come back to these just because I want to make sure that we finish all the topics. And I will come back to these. So let's cover primary open angle glaucoma. I'm happy to stay back to answer questions from anyone with the rest of the team. So primary open angle glaucoma. So we're going to talk about the other type of glaucoma. So this is still high pressure, but open angle. So we talked about closed angle. So why do we get open angle? This is where the drainage of the aqueous is impaired due to disruption of the trabecular meshwork channels. So the aqueous is produced over here. It goes into the posterior chamber, through the pupil, into the anterior chamber, and it's drained mostly through the trabecular meshwork. And you can think of that as small holes, as you can see here, that it drains through. So normally, over time, these holes can basically get blocked up with kind of debris, like dust and fibrin and things like that, that normally just drain through, but sometimes block these holes. And if you think about it, if you block the normal drainage pathway, then the angle is still open. That's why it's called open angle glaucoma, but the aqueous just can't go through as much through these holes. And that's where you get primary open angle glaucoma. What are the risk factors? Old age. The older you get, the more kind of debris you're going to get filling those spaces. Afro-Caribbeans are more likely to get it. If you've got a family history, you're more likely to have open angle glaucoma. And this is opposite. So remember we talked about closed angle, it's the small eyes that are more likely to get affected. So those are your hyperopic, your long-sighted. Myopia, so short-sighted people are more likely to get the other type, the open angle glaucoma. And then diabetics and long-term steroid drops are two other risk factors. No one really understands the mechanism behind why they are more at risk. Clinical features, it's very, very slowly progressive. Think about all these small pieces of debris blocking these holes. So normally patients have no idea that they've got open angle glaucoma. They don't get pain because the pressure goes up very, very slowly. And you might be 25 rather than the 40 or 50 you see in angle closure. And they have no idea. Usually they're picked up by opticians at random eye tests. And one of the things that opticians normally see is the optic nerve gets affected. So this is a fundus photo when you look at the back of the eye. Don't worry, even as ophthalmologists, fundoscopy is hard. We use slit lamps, so don't worry if you can't see this. No one will see this with just their fundoscopy. This is your optic nerve. You can see here, this is your disc, the big circle. You can see this mini circle in the middle. That's your cup. So a normal optic nerve should have a cup to disc ratio of about 0.4. So the vertical height here should be about 0.4 of the vertical height of the entire disc. So here we've got about 0.5, 0.6, so not too bad. But that's exactly what I'm trying to point out. Most people with glaucoma have a really, really big cup and then just the normal disc. And that's because the optic nerve is getting damaged. And remember, we talked about why, because the eye is small, it's in a tight socket, the pressure builds up and pushes backwards towards the nerve. And the other thing you get with investigations is the loss of peripheral visual fields. So as the optic nerve kind of fibers die from the outside first, so you kind of lose your peripheral vision slowly. But if you think about it, you're not going to notice that until it's really, really constricted. So that's why most patients don't even know and realize they've got glaucoma. How do you treat it? There isn't any lasers or anything really. It's not really used. You start with drops first of all. So prostaglandin analogs. Remember what I said before, the analogs, they increase the outflow. So they kind of try and break up those holes. So there's more outflow of aqueous. The beta blockers reduce the production of aqueous. So if you've got less aqueous removed, even though some of the channels that they drain through are blocked, you're going to get less pressure. So that's going to bring that pressure down, your IOP. Laser isn't commonly done. And surgery, just remember this name if you can, trabeculectomy. That basically works on the trabecular meshwork and things like that. So main thing is drops go first. Okay. Sorry, just quick question. So open angle isn't actually an emergency. I've only covered it here because most people commonly think, wait, is there only closed angle glaucoma? And you can get asked about it. So just covered glaucoma because it goes nicely with closed and open. Perfect. Okay. So the indication for surgery is basically when you have done all your drops and the pressure's still high. Okay, so 2 more kind of cases to cover. So we're running okay for time. Have a look at this. A 32-year-old man presents to A&E with a 6-hour history of sudden onset flashes of light and a curtain, or in his, sorry, not her, in his peripheral vision in the right eye. A curtain in the peripheral vision in the right eye. He hit his head following a fall down the stairs 2 days prior. Okay, so we swap to the question. What is the diagnosis you would most worry about? Have a look at this. A vitreous detachment, a retinal detachment, endophthalmitis, giant cell arteritis, or cataract. So he fell down the stairs a few days ago and now he's seeing some flashing lights in the peripheries of his vision. Okay, got 10 more seconds. Okay, let's have a look. Perfect, okay. 89% retinal detachment, absolutely right. That is the correct answer. In this case, vitreous detachment and retinal detachment are probably your 2 differentials. Retinal detachment is your emergency. Vitreous we'll talk about is not an emergency. And the question here is really important. What is a diagnosis you would most worry about? So the fact that they're asking, would you most worry about, you're definitely worried about the emergency, which is the retinal detachment. If the question said, what is a diagnosis that is most likely, a vitreous detachment has very similar kind of symptoms to retinal detachment. So that would be quite difficult to say, but would you most worry about? Definitely a retinal detachment. And cataract is very, very slowly progressive. Giant cell arteritis, we've talked about your jaw claudication, your scalp pain, your shoulder pain, and your endophthalmitis is usually an infection, a big infection after kind of a cataract surgery or an intravitreal injection in the eye. Perfect, so let's go back to the slideshow. Okay, and here just to note trauma as well, that definitely makes you more likely for a retinal detachment. Okay, so let's go over the anatomy first of all. This is your cross-section of the eye, this is your nerve. So here you've got your lens. So this bit here is basically your jelly. If we talk about normal eye, this big bit here is your jelly. And then at the back, you've got your retina. That's what we normally see in that fundus photo, the orange with the nerve, with the blood vessels. That's the retina that we're seeing. So the retina is made of lots of different layers. And it's really important to remember this. The retinal detachment is when there's a break and part of that retina kind of pulls away from the lower part. So it's the potential space between the neuroretina and the retinal pigment epithelium, which is normally quite loosely attached. They become separated. So you just need to remember that. It's basically where the retina pulls away, okay? Risk factors, any trauma. So here we've got someone who's fallen and hit their head. If you had a previous retinal detachment in the other eye, and if you're highly myopic. So remember what we talked about. Myopic people are short-sighted. They have big eyes. And if you think, if you've got a big eye, you're just more at risk with all that pressure and kind of things at the retina tearing and pulling away. So think of it like that. They have risk factors. Clinical features, flashing lights, lots of new floaters, and a curtain or shadow over the vision. Those are the really key words: curtain over the vision or shadow, and flashing lights. So these two, the top two, you'd also see in a vitreous detachment, which we'll talk about. It's a curtain that really gives away that it's a retinal detachment. And what you'd see is you see this retina kind of fibrosing and pulling away. You can see here that's the kind of difference in shade is really kind of the retina pulling away. And this is an emergency. Refer immediately to ophthalmology for surgery. And we basically remove the jelly. That's a vitrectomy. Ectomy means removal. Vitreous is a vitreous jelly. And then we kind of laser that part, and we usually put gas in to stick it down. Just very quickly to cover, what is a vitreous detachment? So a vitreous detachment, you've got a jelly there, which takes up a big space, as you can see. As you get older, that jelly kind of hardens and shrivels up, and it basically can become separated from the retina. So when the vitreous pulls away from the retina, that's a vitreous detachment. Completely normal. I've actually already had that. A lot of people who are short-sighted get that quite early. That's normal. That's not worrying. We don't need to do anything about that. A retinal detachment is when the retina, the outer layer of the retina, pulls away from the inner layer of the retina. So retinal detachment is an emergency. A posterior vitreous detachment is not an emergency. We just call it posterior because the vitreous usually pulls from this side of the vitreous rather than the front, as it shrivels up over time. Perfect. Okay, the last case. Here we go. A 58-year-old lady presents to A&E 4 days after routine right eye cataract surgery. So it's gone really well. Except now, 4 days later, she has very red, very painful right eye, and she can't see she can't basically see nothing. As you can see here, we've got that hypopium, which we talked about. We've got a really cloudy cornea. The eye is red, and her vision's really poor, so we can't even get a 6/60, which is what we talked about. It's even worse than that. She can't read any letters on the chart. She can only count fingers. So, last question of these cases, I should say, sorry. Here we go. Doing really well, guys. What is the most likely diagnosis? Endophthalmitis, keratitis, acute anterior uveitis, angle closure glaucoma, or giant cell arteritis? Okay, so let's see how we've done. Brilliant. So we've got endophthalmitis, 72%, acute anterior uveitis, and a few of you going for the others. The correct answer here is endophthalmitis. The giveaway here is the fact that she's had recent surgery. So we've gone and done something to the eye, and then she's got an infection. So as with any surgery, you're very high risk of infection kind of affecting the eye, especially when you've gone into the eye yourself. Acute anterior uveitis, you're not really going to have a history of recent surgery. They usually come on kind of by themselves, and they get the kind of photophobia as a big symptom. But with that recent cataract surgery, you're most likely thinking this is endophthalmitis. Also, the vision is so poor. Usually the vision doesn't go that bad with acute anterior uveitis. Keratitis, we've talked about more, thinking contact lens wearer. Acute closure glaucoma, no real risk factors there. And giant cell arteritis, no, nothing there to suggest that. So well done, guys. Most of you are getting that. If we quickly go over the case. Okay, so what is an endophthalmitis? It's a very serious but rare inflammation of the interior part of the eye. It's almost always infective, but mitis technically means inflammation, endophthalmitis, which means the entire interior of the eye. It's called a panophthalmitis if it includes the muscles and the orbital fat surrounding the eye. Risk factors, any recent surgery, if they've had a complication in the surgery, but sometimes it can happen with routine surgery as well. If the patient's immunocompromised, they're already at risk of more infections. And lid hygiene, really important one. If people have got had a big surgery where we've made holes in the eye, and then they've got kind of really bad lid hygiene, lots of bacteria and things sitting in their eyelids and eyelashes, then that's really likely to potentially get into the eye. So we always tell our patients after surgery, please clean your eyelashes very, very regularly. Clinical features usually happens within 1 week of an injection or surgery. That's what you've got to look out for in your MCQ. Severe pain, severe loss of vision, red eye hypopia can happen with other things. So you're really looking for that 1 week of surgery presentation. Organisms, once again, your staph, because they usually come from the skin. And then treatment. So really important to treat this very rapidly because it can progress and potentially lose your vision permanently. What we do is kind of like how we treated that corneal keratitis, so the corneal infection. We took a scrape and we send it off. So what we do here is we take a sample from the aqueous, so that was the fluid that we talked about with glaucoma, and we also take a sample from the vitreous jelly, and then we give them big, broad spectrum antibiotics into the vitreous, so right deep into the eye to try and kind of get rid of as much infection as we can. And then if the sample grows anything within a few days, we can change the antibiotics. Oh, sorry. There we go. So that's your endophthalmitis. Fairly straightforward. Think within 1 week of a surgery, an eye surgery or an eye intervention, really severe pain and loss of vision, lots of inflammation going on with the hypopia and the white blood cells. Take a sample from the aqueous and the vitreous and then put intravitreal antibiotics. Whereas with the keratitis, with that cornea, because that's at the front of the eye, we could treat it with the antibiotic drops. Okay, I know that was really, really fast and a lot of kind of stuff covered, but hopefully, I know ophthalmology is not covered very well. Usually do about 3 or 4 days at medical school at most. So hopefully that was helpful for you guys. Just to finish off, we've got kind of a quick question, just to kind of end on a bit of fun. Very, very hard question, something that I didn't know, but I've seen it come up in my finals at Cambridge. So let's go on to, okay, so this is the final question. Remember, this is, oh, is that working for you guys? Okay, so have a look at the question. Fast as you can. Okay. So, wait, did you guys see the question? I can't actually see. Shoaib or Zach or Azim there? Can you guys see the question or?
Hey, Aaron, you can hear me, yeah?
Yeah.
Yeah, so go back a slide. Hopefully everyone can see it now.
I can't see the question, so this is a bit awkward.
Oh no, okay.
Can no one see it?
No, I think, oh, never mind. We'll have to leave the quiz for today.
We'll have to leave it. Sorry about that, guys. But we'll go back to the slideshow. Basically, I can quickly talk you through it for anyone who can't catch the presentation. Sorry about that. Basically, the question was about pharmacological side effects of drops. So just so you know, a very, very common, very difficult question. It's just if you know it or you don't. Which of the following medications can cause acute angle closure glaucoma? And the answer is, does anyone know? I'm just going to put it in the chat. Someone knows. It comes up a few times. Yeah. Oh, wow. Someone's got it. Topiramate is actually the answer that I was thinking. A rectal. So topiramate is the answer. So I don't know who full stop is, but well done. It's very, very, very difficult question. Topiramate. So I'll just put it in the chat. Is a question that comes up before. Causes acute angle closure. That's you are made to be ophthalmologist. Just quick kind of buzz kind of things that can come up. Chlorpromazine causes retinal problems. Topiramate is an anti-epileptic medication. If they ask, chlorpromazine causes retinal problems, and amiodarone is the other one they commonly ask about, causes corneal problems. Perfect, Paris. Yeah. So those three, know those. Chlorpromazine, retina, acute angular closure, topiramate, and amiodarone causes corneal problems. So really, really well done for anyone who knows that, but now you all know it. So well done, guys. I think that's the end for the slideshows. Or just a quick recap of the 6 things that we covered. Bacterial keratitis, these are really the summary slide. Contact lens wearer with a red eye, you're thinking of bacterial keratitis. Just a quick 5 questions. What is the most common organism? Does anyone remember? It was a Pseudomonas. Brilliant. Very painful red eye with reduced vision after surgery, think endophthalmitis. Orbital flaw, most commonly infected in a blowout fracture, your maxilla bone. Risk factors for acute angle closure, hypermetropia, remember small eyes, the angle's already quite narrow. And most definitive imaging in orbital cellulitis is a CT head, CT brain. 2 things just for you guys. I know we've covered mainly emergencies today, but just 2 things that can come up and do come up in MCQs. And I think once you know these 2, then you'll be absolutely fine. Cataract, one of the most common things we see in ophthalmology. How would that present? Gradual, really, really slow, over years to decades of progressive loss of vision. Everything we've talked about has been quite acute. And this is a key symptom. If they say they've got glare at night when they're driving, it's almost certainly a cataract. And the other thing is anterior uveitis. I know I've mentioned it before, but that's where you get inflammation of the front part of the eye. Photophobia is the key symptom there, so pain on bright lights. And remember, think the HLA-B27 disease is their risk factor for anterior uveitis. So that would be your Ank-Spond, your Reiter syndrome, your psoriatic arthritis, things like that. So just remember those 2. Remember the 6 emergencies we covered today, plus primary open angle glaucoma. And I really hope that was useful for you guys. And please fill in the feedback form so that I know kind of what you found useful and what you want more of if we kind of go and do another lecture on ophthalmology. I think the feedback form have just been put in the chat. So please, 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 really important to fill it in. Would really appreciate it. Follow me on Instagram and Twitter. I try and put some kind of med student stuff on there. My details are there in the bottom right-hand corner. Email me any questions as well. And I think I'll be hanging around to answer any questions